Great. So I'm David Berman. I'm Director of the Cancer Research Institute at Queen's University. I'm a surgical pathologist specializing in urologic pathology. That's almost the only pathology I do. And I've been doing it for quite a long time. So I'm trying to talk about things using terms that non-pathologists can understand, and I want you to ask me questions if things don't make sense. So I run a research laboratory in my spare time, and I'll talk to you a little bit about that, but mostly we're just going to talk about what's in a pathology report. And let's see if I can get the slide to move. There we go. Why am I doing this? I'm not getting paid for this, but it really makes my life meaningful to connect with prostate cancer patients, because that's pretty much who I've devoted my life to. My father died of prostate cancer in 2015, and he had a 19-year journey that spanned the entire spectrum from active surveillance to radiation to recurrence and androgen deprivation therapy, metastasis, and so on. He lived a good life and he died at 86. But I understand a bit. I was with him at every step of the way. I saw every one of his samples and went to many of his doctor's appointments. So I'm quite familiar with this area, and it means a lot to me. One of the things you can do to repay me, though, would be to drop me a line and let me know what you thought I did well and what maybe I could do better or explain better. You don't need to take a lot of notes from this talk. Not only will I share the slides with you through Rochelle, but there's also some good online resources available, including from this website, mypathologyreport.ca, where an expert GU pathologist, a genitourinary pathologist named Trevor Flood, who I know to be quite good at his job, prepared pretty extensive documentation on what you might find in your pathology report. So it doesn't have as many good pictures as my slides do, and doesn't have any attempts at humor, which I might make from time to time, but it's a good resource. So as you all know, prostate cancer usually comes to clinical attention by virtue of rising PSA. So rising PSA is pretty good at identifying men who might have prostate cancer. It's right about, it's correct about a third of the time, and the other 2 out of 3 times it's a false alarm. And because of that high false alarm rate, we have to do these barbaric procedures called prostate needle biopsies. And I think probably most of the men in the audience know about this procedure, unfortunately, where 10 to 12 or maybe even more needles are inserted through the rectum into the prostate, yielding, each one of those sticks yields a tiny piece of tissue. It's about 1.5 centimeters long and only 1 millimeter in diameter. And that's what pathologists like me get to look at under the microscope to make the diagnosis of prostate cancer. So not only is this exquisitely uncomfortable, but it also has significant risks of bleeding and infection and hospitalization. It's around 1%, the risk, but so many hundreds of thousands of men get biopsies that's a lot of men. And there even have been some studies that describe a measurable but tiny increased risk of death associated with this procedure. So one of the things that my lab is most interested in and focusing on most at the moment is to replace prostate needle biopsies at least sometimes with urine or blood tests. This is me at the microscope. I think the grad student found a good picture of me looking at a prostate needle biopsy. And the two things we usually get out of a prostate cancer biopsy is there cancer? And if so, what is the grade? So we'll talk about grade and stage and then margins. And those are the three main things you find in prostate, in pathology reports for prostate. So I like to think of the grade as kind of how fast is the cancer going? How fast are these cancer cells likely to grow and spread? So that's another version of me where instead of a microscope, I'm using a radar gun. Similar concept. We don't really know whether the car's going to go off the road or not, but the faster it's going, the more likely it is for that to happen. And this is a very highly magnified image of what a prostate cancer needle biopsy looks like under the microscope. And let's see, whoops. I'm looking for a pointer here. There we go. So over here, can you guys see my red light that's circling around the middle of the slide? You're muted, but yes, I see nodding heads. Okay. So that's a benign glandular structure. It's one of the tubes in the prostate where the fluids that the prostate makes that are there to nourish sperm and help with reproduction, they get transported through these tubes. And almost all the rest of these tubes that you see are made by cancer cells. And the shapes of these tubes determine the grade. So a low-grade cancer gland is what we call these collection or tubes. Looks like this, where there's just one single layer around a central tube or hole, or the technical term is lumen. Each of these cells has a very similar relationship to all the other cells in the gland. It makes a perfect circle. Each one of these cells contacts also the benign cells around the gland. So these are low-grade cancer glands. And let's contrast that with these guys over here, where the cells have quite a variety of relationships to each other and to the surrounding benign cells. So if you're a cancer cell in this gland, you may be surrounded by other cancer cells. You may or may not touch one of these tubes. You may or may not touch the benign cells on the outside. And it's the ability to break these rules that is very strongly associated with the ability to grow and spread outside of the prostate. And that's what harms patients with prostate cancer. So these are high-grade prostate cancer cells, and these are low-grade prostate cancer cells. And you'll notice that this patient's biopsy has both. And that's really common. It's very rare that we see, or it's fairly unusual that we see purely high-grade, though purely low-grade is actually fairly common. So, but the proportion of these also matters, and I'll show you that on a subsequent slide. So here is how long a patient lived after surgery, a 20-year charts. And in black is the proportion of men who died of prostate cancer. And in gray, the gray curves represent the proportion of men who died of other causes. And it's important to look at men who've been treated by surgery, because that's the only way we can get a really accurate view on of their grade. That's one of the unfortunate paradoxes. So the men with radiation, we have a good guess, but we haven't been able to look at all the cancer. We don't really know what the grade is. So what these, the important thing to know is that if you have pure low-grade prostate cancer, there's almost zero chance that you'll die of prostate cancer after prostatectomy, even 20 years out. If you have mostly low-grade and a secondary component of high-grade cancer, you're much more likely to die of something else than prostate cancer, but there is a measurable death, and here it's around 10% at 20 years. If you have more high-grade than low-grade, that's this category here. You have about equal chances of dying of prostate cancer versus other causes 20 years after surgery. And if you're pure low-grade, there's a slightly higher chance of dying of prostate cancer than other causes. On the right here, I've done a conversion of what's called the Gleason grade, which is a very complex grading system, to a simpler grading system called grade group that's come into use more recently. These are the 4 grade groups shown here. I'm not going to explain Gleason grading in any more detail because I don't think it would be a good use of our time. But that website that I pointed you to provides additional information if you need it. There is one other grade group called grade group 5. It doesn't behave that much differently than grade group 4, a little bit worse prognosis, and we don't see it very often. Here's some more details about grading that, again, I'm not going to go over today. So if you have pure low-grade cancer, you go on active surveillance, and the aim of that is to make sure that you don't get a higher grade cancer, at least not while you're a young enough man to benefit from some kind of treatment. So you can stay on active surveillance for a long time, for many years. And the main reason for leaving active surveillance is detection of a higher grade cancer. And it turns out, somewhat surprisingly, that usually that higher grade cancer was probably there when you were originally diagnosed, but just not recognized because the vagaries of the biopsy procedure were not that good at aiming the biopsy gun at cancer. MRI has made that a bit better, but there's still problems with it. Now we're going to move on to stage. So if grade is how fast you're going, then stage is how far you've traveled and whether you're even on the road anymore. So as I mentioned, if a car is going 200 kilometers an hour down the highway, it's a lot more likely to run off the road. Those would be high-grade cancers. This is the one picture I saw of a car going off the road, and I think it's on its way into the water. So more formally, the main stages we look at are confined to the prostate, which we usually call T2, extending outside of the prostate, which is actually T3A, involving the seminal vesicle. Oh, I don't have that pictured. Sorry about that. That's T3B. Well, that's here, the seminal vesicle. So that's, pretty far out of the prostate. And so pathologists can document those stages. There's something called T4 where it grows into other organs like the colon. I can't remember seeing that, certainly not in the last 10 years. So that would be something the radiologist would be more likely to be able to report on. We do report on lymph nodes when they are provided as part of the prostatectomy procedure, and those are important for prognosis, and I'll show you that. Another place that prostate cancer often metastasizes to is bone. Pathologists almost never get those bone specimens, so that would also be more of a radiology issue. Same with metastasis to distant organs. So my father died of metastasis to his liver, and there were no biopsies taken. I think that was just diagnosed by radiology. So here's how stage relates to chance of death within 20 years after prostatectomy from that same paper. And I should mention that this paper was published in 2011 based on cancers that had been diagnosed 20 years earlier, or 10 to 20 years earlier. So there have been treatment advances since then, and I would expect patients to do a bit better. But the effects or the influences of each of these factors probably still remains the same relative to one another. So it's still best to have cancer that's only inside the prostate. That's the lowest stage, that's T2. It's a little bit of a higher risk if the cancer involves the soft tissue just surrounding the prostate. That's T3A, that's this category. Seminal vesicle involvement has a much higher risk of death from prostate cancer, and spreading to lymph nodes has a higher risk associated than that. Finally, we're going to move to margins in the prostate. So after the surgeon takes the prostate out, it comes to the pathology lab, and we paint it with ink to demonstrate the edge of the specimen. So here you can see some green and black ink, and this cancer gland here extends all the way and touches that ink. So this is what's called a positive margin, meaning the surgeon did not successfully remove all of the cancer from that patient. Here is some blue ink on the edge of a specimen with a negative margin. Here's some benign cells, and the cancer's up here. So that's what a negative margin looks like. Turns out that margins, when you put them into an equation with all of the other factors, don't have nearly as strong an effect on survival as stage and grade, but they are linked with the likelihood that the cancer will come back after prostatectomy. So for example, that PSA will become elevated and start to rise at some time after surgery. So I've shown you some examples of how we refine grading systems and staging systems. It's all by looking at outcomes of men and correlating those outcomes with different properties or different factors that we can examine in the pathology specimen. And here's an example of something called the CAPRA-S score, which dictates the likelihood that cancer will recur after prostatectomy. Now, I told you that there's not a perfect relationship between recurrence and death. A lot of things that that lead to recurrence have not necessarily been statistically significantly associated with death. And a good way to think about that is there probably are cancers that would take 30 years to kill you, and if they recur in a 70-year-old man, it's so much more likely to die of something else that that factor won't be important. So here's the CAPRA score, which you should take in a little bit of a grain of salt, but again, those factors that are associated with high risk of recurrence are going to be associated with higher risk of death. And here you have those various factors I showed you plus PSA. So PSA, surgical margins, negative or positive, seminal vesicle invasion, Gleason, extracapsular extension, so that's that T3A stage, and lymph node involvement. So you put these into an equation, and the higher the score, the more likely the cancer is to recur. Again, this was done in 2011. Patients will do better now, given the some of the advances like advanced androgen blockade and better control of local disease. So, in summary, grade is a measure of how fast, or it reflects how fast the cancer is growing and spreading. The stage is how far the cancer has grown and spread, and the margins reflects whether or not the surgeon removed all of the cancer. And as I mentioned, I will share these slides, and there's plenty of time for questions.